My name is Monica Ruiz, and I'm happy to be here as part of the Effie Berry Training Institute to talk to you about policy and HIV program implementation. Just as a disclaimer, this program is funded wholly or in part by the government of the District of Columbia, Department of Health, HIV/AIDS, Hepatitis, STI, and TB Administration, also known as HOSTA. So for a bit of a presentation outline, I want to talk to you first about looking at social determinants, understanding what they are, just a brief recap of definitions, looking at what health equity is and what health inequities are, and also to cover a bit of an interactive activity. If we were together in person, we would be stopping at that point in the discussion, and we'd be having an interactive activity. But I do want to share it with you in this virtual format so that you can take time later on to perhaps do it on your own or do it with a colleague, because I think they would be helpful in really understanding how social determinants and issues of health equity and inequity affect access to care and the delivery of care. To proceed, we're also going to talk about policy as a structural barrier to HIV program access and utilization, and policies affecting vulnerable populations. With this, I will be sharing some of my own work in harm reduction and reaching out to injection drug using and polysubstance using populations, and looking what policies have been in place for those populations that make access to care and health equity a difficult issue. We'll also look at policy barriers associated with healthcare access, more specifically looking at issues associated with insurance coverage and navigation. And we'll also talk about recognizing and addressing what these structural barriers are and what we can do about them and how we can work towards health equity. And that will lead us to our second interactive activity, which, again, as I mentioned, if we were together, we would be stopping at that point in the presentation to do the activity as a group, but at this point, since we're all virtual, we could do this online. We could also talk about it a little bit later in the discussion section after this video airs. So first, let's talk about social determinants of health, health equity, and health inequity. So what are determinants of health? So determinants of health are the many factors that come together to affect the health of individuals and communities. And we know that health status is determined by a variety of factors, including people's circumstances and their environment. This is where we live. This is the state of our government, or both federal and local. This is our income and education level. This is also our access, our utilization of healthcare services. And these determinants are very broad. They include the social and economic environment, the physical environment, as well as individual characteristics and behaviors. So when we talk about health disparities, what are we talking about? These are the differences in the incidence, prevalence, mortality, burden of disease, and other adverse health conditions that exist among specific population groups. And these can affect us based on gender and sex, based on age, based on race, ethnicity, our socioeconomic status, our income levels, our geography, rural versus urban. There are many access to care differences in urban populations compared to rural populations. Sexual orientation can also be a factor that affects health disparity. Disability, as well as other special health care needs, for example, mental illness. We also know that health disparities disproportionately affect groups who have experienced a variety of other significant issues, such as persistent historical trauma, social disadvantage, discrimination, and systematically worse health or greater health risks than more disadvantaged, more advantaged social groups. So this is something that we see especially with communities of color, especially with African American populations, Native American and indigenous populations, and also Latinx populations, among others. So when we're looking at health disparities, a lot of times the words health disparities and health inequities get thrown around a lot. They're not synonymous. So health disparities are the differences in the presence of disease outcomes or access to health care between population groups. So these categories reflect social advantage or disadvantage. For example, they determine an individual's position or a group's position in a social hierarchy. And these are likely to reinforce already existing social vulnerability and disadvantage. When we talk about health inequities, these are differences in health that are not only unnecessary and avoidable, but also are considered unfair or unjust. So these are the things that are rooted in the social injustices in our society that make some population groups more vulnerable to others with regard to poor health. So when we look at the 7 major determinants of health disparities, there are some that we can call unavoidable or fair. So for example, natural biological variations. So these are the things like genetic predispositions. This is something that affects everyone to some degree or less. This is not something that we can control. It's not something that's necessarily unavoidable, or that is avoidable. It's not necessarily unfair because it doesn't disproportionately affect certain groups over others. This is also freely chosen health damaging behavior for individual choices to smoke, to drink, what have you. And this could be the transient health advantage of one over another. So for example, early adopters of health promoting behaviors may have a slight health advantage, but when other people catch up, that advantage kind of levels out. And that's fair, that's reasonably fair, that's unavoidable, etc. When we think about those things that are avoidable or unfair, these are things like health damaging behaviors or a degree of lifestyle choices are severely restricted. So when we talk about, for example, obesity in certain populations that are low income, have low access to resources, etc., we can't necessarily blame people for unhelpful choices when there are no helpful choices around in their environment. That's just, that's a classic example. If someone's living in a food desert, you can't expect them to eat healthy foods all the time because they simply don't have that access. This is an unfair and avoidable situation. Also, exposure to unhealthy, stressful living and working conditions. Again, being in an unhealthy, stressful living and working condition is something that ideally should be avoidable. It is also unfair. It's unjust. It doesn't have to be that way. And a lot of those things are rooted in disparity and health inequity, right? Also, we're talking about inadequate access to essential health and other basic services, our basic access to care issue that disproportionately affects people in an unfair and avoidable way, as well as things like natural selection or health-related mobility. This is the example of sicker people moving down on the socioeconomic scale simply because they are sick. So because they are sick, they are unable to access services, or they may have poorer access, or they may have to access services more frequently and therefore miss out on work and are unable to hold jobs, etc. So this is this kind of downward unfair health-related mobility that should be, as I said, is unfair, but also should be avoidable, right? And so an inequity is said to exist when a health disparity is determined to be avoidable or unfair. So again, at the top of the level, at the top here, it's the unavoidable or fair. Those would be our health disparities that are, again, not necessarily justified, but these are things that do play out. But our health inequities are really those things that are unfair or avoidable. And health disparities should be examined in both qualitative and quantitative terms. Unequal health outcomes at an individual level do not always correlate to systemic or systematic inequities. This is not to say that they can't, but they don't always do that. So when we look at social determinants as structural barriers, we have to understand that many of these determinants are structural. They're things that are rooted in stratification of society. So for example, distribution of income, class discrimination, etc. These are things that are part of the political structure that reinforces rather than reduces inequities. And this is something we're seeing in our population and in our country right now. And this has the most impact on these intermediary determinants: the living conditions, the psychosocial circumstances, the access to resources and services that are necessary for good health. So again, this is something that is unfair, should be avoidable. And it's important to understand that these structural factors may affect health access and utilization regardless of an individual's desire or intention to engage in care. And so this, because these factors are present, these barriers are present, they may serve to promote health inequity as well as health disparity. So this leads us to our first activity. So our first activity is focused on understanding the differences between health disparities and health inequities. So I'm just going to walk you through it. Hopefully you'll have a chance to do this on your own or in our discussion section, but I'm just going to walk you through it right now. So think generally about the context of healthcare in the District of Columbia. So how would you, as a provider, as someone in the healthcare industry, how would you describe the general state for health for DC, and why would you describe it that way? And then think about the specific population that you or your program serve. How would you describe your client's health status, and why? What would make you describe them in that way? And then think again about the population that you and your program serve and the disparities and inequities that they experience. So keeping in mind our definition of health disparities and health inequities, how would you complete the following table? So if you look at different categories, what are some of the disparities that you see associated with sex or gender or race or income or geography, etc.? Or nativity or immigration status. That's a really important one nowadays. Who's experiencing this? Is this also a health inequity? And what can be done about this, right? So on your own, or perhaps in the discussion section, we might have a time to go through this table and complete it. But it's certainly worth the exercise to really kind of understand the differences between disparities and inequities. So I'm going to launch into the second section about policies as structural barriers for HIV programs. So why it's important to understand why social determinants and health disparities are important, and how we define disparities and equity can have really important policy considerations with very practical consequences. So these can determine which activities are monitored by governmental agencies. These can determine which activities receive support or don't receive support, right? So understanding how these definitions work in a policy framework is really critical to seeing what programs actually get supported on the ground. And policies, both governmental and social, affect a variety of groups that are at greatest risk of HIV infection and are disproportionately affected by the HIV/AIDS epidemic. So, for example, transgender and gender nonconforming persons are disproportionately represented in our AIDS numbers. People who inject or use drugs, also known as PWID, also part of this group. Persons engaging in commercial or transactional sex or survival sex. Persons transitioning into and out of correctional facilities, back between corrections and community and back and forth. And as well, it's important to understand that there are intersectional identities among all of these groups. People aren't necessarily in one category, and so they can be a variety of things and have a variety of risk factors from a variety of different identities. So just to think about persons who inject drugs and persons who use drugs, there are legal status of behaviors that are associated with HIV risk. So as we know, most street drugs are Schedule I substances. They have a legal status, and there's no regulatory control over the product itself. And this is something that we're seeing in the District of Columbia. We have an opioid epidemic that is out of control in our nation, but also something that is really hitting DC very hard. And there's no regulatory control over the product. So when people think they're buying heroin, it could be heroin plus something else. There's a lot of fentanyl, carfentanil, all these other fentanyl analogs around that are hugely dangerous, right? And so again, because it's illegal, because there's no quality control, no regulatory control, people don't know what they're getting, and that increases the risk not only of HIV transmission and sharing needles, but also in terms of overdose. We also know that prescription opioids are Schedule II substances. They are legal, but they're highly regulated. They're very, very hard to get for people who don't have a prescription, and it's very, very difficult to get that. And so people will often transition from prescription opioids to street opioids like heroin and fentanyl. And we also know that the addiction to drugs, other than tobacco and alcohol, are still highly stigmatized. There are significant barriers to treatment options. We talk about addiction in a way where we're having better conversations about addiction now, but we talk about addiction in a way that is not the same way we talk about tobacco and alcohol addiction when we apply it to opioids or methamphetamine or any other sort of drugs that are street drugs. So we have to understand that in and of itself is a barrier. And this can affect not only treatment options, but treatment acceptability. And we definitely know that there are criminal justice approaches and interdiction approaches that are prioritized over approaches to prevention and treatment. There's a lot more time and money spent on arresting and incarcerating people for substance abuse issues and mental health issues when we should be spending that money in my personal view, on prevention and treatment, and helping people avoid those consequences. And so we also have public confusion over what needle exchange is and isn't, because needle exchange is an important structural intervention for HIV prevention, as I'll tell you in a minute. And when we try to talk about needle exchange and harm reduction, people believe a variety of things that we know are not true, right? People believe that needle exchange promotes drug use, that it increases crime, that it undermines law enforcement's effort for drug control, and that it's a hazard to public safety. What we know from research that has been done to investigate all of those claims is that there's no evidence that needle exchange programs increase drug use or crime. There's no evidence that shows that needle exchange compromises public safety. And there's no evidence that needle exchange programs undermine law enforcement efforts. So again, having that public confusion also contributes to the barriers to accessing these programs for people who inject drugs. And it increases the level of stigma around not only substance use, but also harm reduction and efforts to try to prevent and treat substance use in these populations. So when we talk about needle exchange and HIV, needle exchange programs made their first appearance in 1983 in Amsterdam, in the Netherlands, after a local pharmacy stopped selling sterile needles and syringes to injection drug users. And so community members, local community advocates got together and they started doing this stuff on the street, this giving out, making sure that drug users had clean needles, so they were lowering the risk of HIV infection and taking those used needles, getting them out of circulation and disposing of them properly. The first syringe exchange programs or needle exchange programs in the US were established in the late 80s in Tacoma, Washington, Portland, Oregon, San Francisco, California, and New York City, New York. And since the implementation of syringe exchange programs, syringe services programs, HIV incidence in injection drug using populations in the US declined by approximately 80%, which is phenomenal. Injection-related transmission is the only category of HIV infection among adults to show declines of this magnitude. The pictures here are from some of our harm reduction heroes, HIPS, an organization you may know about. They do phenomenal work in the district providing comprehensive harm reduction services. The picture on the other side, the gentleman in the red, is the godfather of harm reduction in the District of Columbia. My personal view, again, Ron Daniels, amazing man, may he rest in power, did so much to get out there and provide services to clients in the district. And what you see in the middle is the Prevention Works van. Prevention Works was the first needle exchange in the District of Columbia. And I'll talk about them in a minute. And the van is parked right in front of the Capitol. So just want to put that there. So when we think about syringe exchange, there are a variety of regulatory and policy issues that affect people who inject or use drugs. So as we know, there are drug paraphernalia laws that govern the sale, the distribution, the possession of syringes, including over-the-counter sales at pharmacies. It used to be that if you wanted to go buy syringes without a prescription in a pharmacy, you weren't able to. And especially if you looked like a drug user, that made it even more difficult. Pharmacists could decide that they were not going to sell to you, and you're out of luck. You can't get what you need. You can't get the resources you need to stay healthy. So that was an issue. Speaking of which, those prescription requirements for syringe sales are stringent, right? And so many pharmacies still require a prescription to get access to clean needles and syringes for any sort of injection. And if you are an illegal substance user, then getting those prescriptions is probably going to be really, really difficult. There are also drug possession laws that come into play. So with the drug possession laws, if you are carrying your own needle and syringe and you have even a scintilla of drug residue in that, you could be charged with drug possession. That in and of itself is a barrier for people trying to carry their own equipment for injection, because if they are to get caught, it increases their chances of a negative consequence. There's also issues of public and private funding for harm reduction approaches. And I'm going to talk to you a little bit about the DC ban, which was in place from 1998 to 2008. And there's also the explicit versus implicit legal authorization for access that come into play in terms of zoning laws and things like the 1,000-foot rule, which is still a policy in the District of Columbia. So to talk a little bit about the DC ban. In 1998, Congress included language in the Financial Services Appropriations Bill prescribing the use of federal funds for syringe exchange. And so this legislation did not affect states or other localities outside of the District of Columbia because they were able to use their own municipal revenue. They couldn't use federal monies, but they were able to use their own municipal revenue if they wanted to create a needle exchange program or something like that. The District of Columbia, however, could not do that. We are not a state. We're under government control, federal government control, and so DC was not allowed to use its own municipal revenue, and certainly couldn't use federal revenue, to create a syringe exchange program for the injection drug using population in the district. And so what happened was that Prevention Works came up, and this was an NGO that was supported through private donations and grants from non-governmental charitable organizations, and they operated the only syringe exchange in town while advocates continued to try to get this language removed from the Financial Services Appropriations Bill so that municipal revenue, DC revenue, could be used to support harm reduction. And this policy change actually went into place in 2008. So at this time, at the time that this was going on, this was an estimated 1 in 30 adults in the District of Columbia were HIV infected. And so we had a generalized epidemic on our hands. We had a lot of injection drug use driven new infections. And so it was really important to be able to do something about this. And it was really important for that policy to change so that DC money could be used for that purpose. So where I come into play is, I was part of the advocacy team who worked for the change in that legislation. And so when it happened, I was, of course, ecstatic because, this is a huge policy win for the District of Columbia. But at the same time, the researcher in me is thinking, we have to evaluate this. We need to know if this policy change really had an impact on the number of new infections among injection drug users in the district. And so this was the subject of a study that I was funded by the National Institute on Drug Abuse to examine. Did the removal of the DC ban have an impact on the number of new infections among persons who inject drugs in the District of Columbia? So that is what I'm going to share with you as part of this example. So we did a couple of things. I'm going to share with you the quantitative methods that we did. We looked at interrupted time series analysis, which is a statistical procedure that you can do to look at trends in what is happening over time and examine the impact of an interruption in that trend to see if it made a difference to what happens later. And we used mathematical modeling to estimate the number of infections that were averted by the policy change as a structural intervention for HIV prevention. This is a research design. We also looked at Baltimore and Philadelphia. Those two cities also required changes in policy for their harm reduction programs to be put into place. And so we wanted to look to see how it differed from city to city. But this is pretty much the timeline here. And we were using monthly surveillance data from the District of Columbia Department of Health, from HOSTA, looking at the time that the ban was in place for those almost 10 years, and then what happened after the ban was lifted. And here's what we found. So this blue line are the squiggly line here is the reported cases of HIV infection. And as you can, and the red vertical line is the interruption. And so what we're seeing here is that, and the green line is the confidence interval. So using this model, we developed a forecast of the number of expected cases for each of the 24 months following the interruption. And so this reflects the number of cases that would have occurred in that month in DC had the policy change, that red vertical line, the interruption, not occurred. So as you see, there's a drastic decrease in the number of reported cases of HIV. But what we found is that the surveillance data from the Department of Health reported 170 observed cases of HIV in the district in the 2 years following the repeal of the DC ban. In contrast, what our model showed is that we would have expected 296 HIV infections if nothing had happened. If that ban had stayed in place, we would have expected 296 infections. What we saw was 176. So this resulted in 120 averted cases of HIV in the District of Columbia in 2 years. And when we think about what this means for policy, right? Understanding what this means in terms of cost savings is tremendous. The fact that we had 120 averted infections was in 2 years was great. But the fact that we can save a tremendous amount of money by now not having to support HIV care for those people who are not infected is also tremendous. And when we think about what this means in terms of advocacy and policy change, legislators always like to know, so what's this going to cost me? What's this going to cost the taxpayer, et cetera? They listen to the dollars, right? And so if you think about the average lifetime cost of treating HIV infection in the 2010 estimate that we were using was approximately $380,000 US, right? This is just treating HIV infection, not treating comorbidities, mental health issues, substance use treatment, and just HIV infection. But if we just focus on that, if we look at 120 cases of HIV infection averted in 2 years, multiplying that by $380,000 per case, what we're looking at is a cost savings of almost $46 million annually, which is pretty great. It's actually a very, very compelling argument for why harm reduction is not only effective for public health, but effective and cost savings to the taxpayer. Understanding that many folks who are in this population of injection drug users are getting publicly funded health care. So this is a cost savings for everyone. Everyone wins as a result of this. To switch gears a little bit, I want to talk a little bit about the impact of the 1,000-foot rule. So the 1,000-foot rule is something that is still in the code in the District of Columbia, and this is regarding the conduct of needle exchange programs. And it says the drug paraphernalia cannot be distributed, in anywhere near within 1,000 feet of a public or private elementary or secondary school, including a public charter school. So when we think about what this means, the District of Columbia has about 61 square miles of physical land space, and it has 8 wards, as you know, with significant health disparities in many of those wards. And at the time that we did this analysis, there were approximately 335 schools currently in operation. There are a lot of schools in the District of Columbia, a lot of schools. So when you think about where those schools are and map out 1,000 feet around those schools and then try to figure out where the greatest need is, where the highest number of cases of HIV in wards 7, 6, 7, 8, where the population need is versus where those schools are and what we can do, we need to look at. So we can't deliver syringe exchange there, right? So where can we deliver syringe exchange? Where's the legal space that we are able to provide syringe access services to our population, and not violate this policy? And so we looked at this through using a variety of data sources. So we use data from Prevention Works, which is no longer in operation now, but at that time, they were the only game in town in terms of syringe access services, and we used their client data, registration data for each person who presented for services while the syringe exchange program was in operation. We used some population estimation study data that we did ourselves from a different study connected to our research. We looked at arrest data to see where the hotspots were in terms of drug use, drug trafficking, drug arrests, kind of mapping out where things were happening and therefore where the greatest need might be. We looked at the DC school locations for 13 years, right? Looking at not only DC Board of Education and DCPS, but also DC public charter schools, and also using publicly available GIS data to map out the other geographic features of the District of Columbia that are off limits in terms of harm reduction. So here is here are our 8 wards in the district. When we map out all the geographical impediments, these are things like federal parklands, military installations, the river, those types of things where it is just not legal to engage in syringe exchange. And then when we put the schools on there, that doesn't leave us much room, right? So in 2002, a picture was worth about 691,941,888 square feet. All that area that is not covered in red are the places that are legally accessible for syringe exchange services. When we overlay this on the areas of greatest need, we see that the places that have more space in the district are the places that are not the places with the greatest need. And so there is a limitation there that enables us or does not enable us to provide the services to the population most need in those areas where they live. Just to kind of put a few numbers to this, looking at, if we look at this by year, we can see that for across 13 years, about 50% of the total operational space was ineligible to harm reduction services and to the delivery of harm reduction services in the District of Columbia. If we look at it by ward, we're seeing roughly the same thing, with wards 7 and 8 being, in this area of, kind of the greatest impact here. And so the conclusions we came to from this analysis is that people who inject drugs in DC have very limited access to syringe exchange services due to these policies, this zoning policy that does not allow syringe access services to happen anywhere within 1,000 feet of a school. And this decreased access results in fewer exchanges, meaning people can't get the resources they need to stay safe, to stay healthy, right? And there's a disconnect between the wards with the greatest prevalence of HIV and the areas where provision is legal, right? And so there's this mismatch. There's these missed opportunities for prevention, missed opportunities for service delivery, which is really crushing when we think about what this means for people getting the resources that they really, really need. And so when we think about what can happen, policy reform is a natural, I guess, sequelae of this. We should focus on revising these restrictions that place unnecessary burdens on harm reduction providers and the people who are providing these services to those who need it the most. So just to switch gears a little bit away from the injection drug using population and onto some others, there are policy issues that affect those who are engaging in commercial and transactional sex work. Obviously, commercial and transactional sex work is illegal, right? And so this may prohibit those who are engaging in this type of work to access social services like housing assistance that they really, really need, because they can't say, this is what I do, because it's not allowable, right? And so they can't access housing assistance by not being able to, by being unstably housed. That provides, tips the domino on a cascade of other things that put them at greater risk of negative health outcomes. Also, really importantly, sex workers who experience physical or sexual violence may be very reticent to report it because of the illegal nature of the work. And this compounds the level of victimization. Not only are they physically or sexually violated, but they're also victimized by the fact that they can't say anything about it, because then they will be ostracized, arrested, et cetera, for engaging in illegal behavior. So this has a kind of a double and triple whammy effect on people who are undergoing these very horrendous circumstances and these very horrendous, experiences of physical and sexual violence. And there have been efforts to decriminalize sex work, and as some of you may have been following this in the district, a lot of these efforts today have stalled. There's a lot of pushback about the legalization of prostitution, even though many places do have legalized prostitution, or at least have some sort of union to enable persons in commercial sex work to get better access to healthcare services. They're also concerned about sex trafficking, which, I don't want to underestimate these concerns, because sex trafficking is a tremendous, tremendous problem, in the United States as well as globally. But again, by decriminalizing sex work, this doesn't necessarily allow for the increase in concerns about sex trafficking. So I think these things need to be addressed and thought about in a much more comprehensive manner. There are also tremendous policy issues affecting transgender and gender nonconforming persons. So the good news is that DC has a non-discrimination law that protects people according to their sexual orientation and their gender identity. This is phenomenal news. However, there are a lot of federal measures that prohibit online portals for sex work solicitation. And again, this also affects transgender, gender nonconforming persons. And it forces people back on the streets, it forces people back in the closets. And that is dangerous because we know that that has negative mental health and physical health effects on these populations and makes them more alienated from care that is truly important. Also, we have seen that hate crimes against transgender persons, particularly trans women, and particularly Black trans women, are at an all-time high, and this is purely unacceptable. This is absolutely unacceptable, as I hope many of you will agree. But this bias against sexual orientation, gender identity and expression, race, and ethnicity makes up about 95% of the reported crimes in 2019. When we talk about that intersectionality between race, gender identity, all these things, this is something that is tremendously difficult. And it's really, really important to understand that while we are, conversely at a time in our society where we have a lot more visibility and acceptance and tolerance and embracing people of gender nonconforming identities, there is also there are also these hate crimes that are so high. And again, this makes people not want to present for care, not want to present for services. It provides a barrier because of the potential issues of discrimination. And this is also part of the global homophobia that not only touches the District of Columbia, but also touches the entire world. And these are things that, affect how we report reproductive and sexual health outcomes, putting bans on terms like sexual health, putting bans on terms like transgender, pushing for anti-gay legislation or having the implementation of anti-gay policies, anti-LGBTQ policies, and how they affect our structures, how they affect our healthcare delivery. Again, these are things to keep in mind because this is something that has a devastating consequence for transgender and gender nonconforming people, as well as for LGBTQIA people most generally. There are also serious policy issues affecting persons re-entering from corrections. So in many cases, re-entering persons have lost their voting rights, so they lose their representation, which is a tremendous existential problem. They've essentially lost their personhood with regard to representation to the state. Many have limited educational levels of work experience, so trying to be able to find jobs and access jobs without the appropriate educational level or without the appropriate training is really, really difficult. Many people don't even have a valid ID, right? They're released from corrections without an identification, without any valid ID, and you kind of need that for things like applying for housing and work and benefits and bank accounts, and not even having bank accounts. That's a tremendous barrier right there. They may not be able to be reunited with their families because of public housing policies that do not allow people with certain types of criminal records, felony convictions, etc., to be in subsidized housing. And so this creates a level of housing instability that, again, certainly not helpful for a variety of physical and mental health outcomes. They may not have access to transportation, whether it's having their own vehicle or having access to money to take the metro or to take the bus or what have you. And that's a huge barrier. Many folks who are reentering have multiple health issues, including substance use and mental health issues that may or may not have been addressed while they were incarcerated, but certainly are not being addressed on the outside. The level of linkages to care from corrections back to community varies. Some people are able to make those connections, some people are not. In many cases, the correctional facilities do not help as much as they perhaps could with making those linkages and ensuring retention and care, which is again tremendously difficult for people who have chronic health issues, both physical and mental health issues. They may not have access to health care in the community for all the reasons stated above, as well as simply not knowing where to find access or not knowing how to access it and not having insurance. And many experience discrimination by potential employers or landlords because of having been incarcerated, which again compounds issues about housing instability, compounds issues of stigma, compounds issues of limited work experience and not being able to support themselves in in a substantial way. When we think about the policy implications for healthcare access, one of the great things that we've been able to see in our recent years is the passage of the Affordable Care Act, which led to significant increases in coverage especially in racial and ethnic groups, a tremendous benefit in that more people have coverage than before. However, there are some groups that are at higher risk from being uninsured, lacking access to care, and they experience worse health outcomes. So, for example, Latinx groups are 2.5 times more likely to be uninsured compared to whites. Non-elderly Latinx, Black, and Native American populations are more likely than whites to delay or to go without needed care. This delay in healthcare seeking can lead to worst case prognoses, etc. So, poor health outcomes in general. And we do know that non-elderly Latinx and Black adults are less likely than whites to have a usual source of care or to have had a healthcare or dental visit in the prior year. So when we think of people having a medical home, routine access to healthcare, regular access to healthcare, and that people don't have a usual source of care. This is a tremendous problem when people are getting sick, when people need continuing care for chronic conditions, etc. And this is something that we are seeing play out, especially in the COVID pandemic, as well as with HIV. And as good as the ACA has been in terms of improving access to care, there have been issues with it. So, for example, funding for prevention and public health has been reduced through cuts to the Prevention and Public Health Fund. And this has been some work of the recent administration. And there are further cuts that are slated. And again, many of the provisions that were part of the ACA to enhance the capacity of healthcare workers did not receive continued funding. So these interruptions in funding resulted in interruptions in care to the people who need it the most. And some healthcare payment and delivery systems and those reforms that were put in place are being phased out by the current administration. So that, again, further reduces resources to address social determinants of health, which, again, exacerbate existing health problems. If we look about the District of Columbia specifically, we have DC HealthLink, and this is the health insurance marketplace for DC. And in 2019, the DC law required residents to have qualifying health coverage, and this is or get an exemption or pay a penalty on their DC taxes. It does have a non-discrimination policy that includes sexual orientation and gender identity, and preventive services are covered without copay, which is fantastic. There's no limit on the number of mental health or substance use treatment visits, also fantastic. And the Coverall DC effort allows residents to purchase full cost private health insurance, even without a qualifying immigration status. So this is tremendous news for people who are here in an undocumented fashion, but who also very much need care and deserve access to care. So while all that is good, there are, as always, some issues associated with the implementation of this policy. It may require assistance to get people connected for coverage. There have been issues with online registration. It requires an email address if you're going to do something online, and many people don't have an email address or are not savvy enough to navigate the online portal to be able to register. It still requires payment of monthly premiums, which again makes sense, but this requires a credit card and a bank account for payment. And if your clients do not have this, then guess what? They're not going to be able to get DC Health, as great as it is. And there are special enrollment periods for those with the declined credit cards, but this only applies if the reason for the decline is not a lack of adequate funds. And so again, for people who are unstably housed, for people who are not working or unable to work or what have you, and who are who are economically insecure, this is still a barrier. This is still a barrier for coverage and still a barrier for access to care. And even though we had that piece before about, regardless of immigration status, immigration status may still be an issue because only those with eligible immigration status can enroll in a private health plan through DC HealthLink. So this may not truly encompass people who are undocumented or who are here and do not fit the definition of eligible immigration status. So moving on to, so now that we've talked about these different policy barriers as structural barriers, let's talk about how to recognize and address them. We've identified some examples. Let's talk about what to do about it. So there is in healthcare the evidence of the social psychological bias, and this is Albert Bandura saying, the quality of health is heavily influenced by lifestyle habits, which we know, and while collective efforts are made to change unhelpful social practices, people need to improve their current life circumstances over which they have control. So this is all fine and good, but this assumes a couple of things. It assumes that people have the agency to be able to have control over their current life circumstances, and it also assumes that their current life circumstances are something that they actually can control, right? And so, where we see our clients in the healthcare system, we're looking at a whole variety of contexts that affect them before we even see them. We're talking about issues of social policy and public policy. We're looking at issues of social class, ethnicity, the impact of racism, different levels of education, their working and living conditions, their psychological factors, their social capital in their communities. All of these things are on them before we even get to see them in the healthcare system. And so it's important to understand that we may see them at a point in time, but we also need to take into account all of those other things that are affecting them before we see them, and that have an impact on the state of health with which they are presenting, as well as what they can do to get to better states of health. And taking racism as one particular example, racism affects health outcomes in a number of ways, right? It affects people's access to education and jobs, which affects their health outcomes. It affects their access to food and their food environment and their socioeconomic status, where they're able to live, which affects their health outcomes. It affects their environmental exposure to things like lead or things like pollution. It affects their health behaviors. It affects their access to services. It affects community violence, right? All these things have an impact on health outcomes. And so we not only need to understand that racism is this terrible social force that has been in our country for hundreds of years as a structural factor ingrained in the nature of our country, but it has these very serious impacts all along the way, which lead to the health status of the person standing in front of you in your clinic or in your organization looking for services. So what I would argue is that we need to change the way we think about disparities. So we need to look at it using the lens of health equity. And so when we think about health disparity, we have to ask ourselves, are the reasons for this disparity fixed, or are they changeable? Are the reasons for the disparity due to differences in the environment? Are those reasons for disparity due to social injustice or preferential treatment or access? Things that we can perhaps change. Are the reasons for disparity attributable to differences in quality of care? And the reason I harp on structural interventions is because structural interventions have been part of, we're part of the AIDS prevention strategy for a very, very long time, but not quite as long as individual level behavior change efforts. So we have focused so much of our time in HIV prevention from the very beginning of this epidemic, focusing on individual level behavior change efforts. And these have been great. They have resulted in anywhere between a 10 and 40% decrease in risk behaviors associated with HIV transmission and acquisition in different population groups, different exposure categories, et cetera. But they can only take us so far, right? They can only take someone to a certain level because there are issues with sustained individual level impact. There are limited resources for continued implementation of some of these really tremendous and very, very popular interventions. And so we have to look beyond those individual level interventions to those social and structural factors that are part of the environment in which people live, that pose barriers to behavior change and pose barriers to healthcare access. And so again, when we think about structural interventions, we're looking at those things to change the environment. How do we change the environment in which that health risk occurs without necessarily trying to change the individual, right? How do we create a healthier environment for people to live in? And these are, again, include policies, but also programs. And I talked a bit about the policies, but also this is also a kind of cue for you to think about what kind of programs are part of those structures that create environments of risk or create environments to promote health. So when we think about interventions at the structural level to improve population health and health equity, we can look at things like having regular screening as part of a service in primary care, improved standards of care, better health education, better programs for self-management, better provider training, right? Better provider sensitivity and cultural sensitivity. Looking at things like safety counseling and distribution of car seats. These are interventions that can improve health and reduce disparities for a variety of different types of disease that can happen in the primary care setting, i.e. a structural setting. We can also think about policy action to improve health equity. So for example, if we want to support and strengthen care, we can not only do that as part of our delivery of care in a clinical setting, but we can also look to expand neighborhood health centers and increase reimbursement for providers and better incentives for preventive services so people can come in when they're healthier rather than when they're sicker, right? There are a variety of things we can do at the policy level, not necessarily like federal policy, but also just healthcare policy to improve how care is delivered and how care is reimbursed. And again, part of this is all working towards this kind of holy grail of health equity. We need to increase access to individual and community-based comprehensive care. We need to improve cultural competence in healthcare systems, and not just cultural, like racial, ethnic culture, but also cultural in terms of LGBTQ and gender, different gender nonconforming persons, and understanding that there is a culture there that requires competency and sensitivity. A variety of other things, mental health, disability, et cetera, that also requires cultural competence. And we also need to identify malleable factors, those changeable factors that influence health and health outcomes and change them for the better. So thinking about things like built environments and food access, things that we can actually make a difference in for people living in these environments. And all of this is part of working to change policies in a way that improves health and reduces disparity. So where are those potential places where we can intervene? Well, what's nice is that in many ways, there are a lot of them, right? We can look at issues of health literacy and provide education to improve health literacy. We can work towards access to healthier food options. We can work towards reducing discrimination in our communities and in our social context. In the healthcare system itself, there are a variety of places for intervention, ranging from trying to improve healthcare coverage to a broader swath of the population, improve cultural competency and linguistic competency in our provider services, and improve quality of care, as well as provider availability. So this leads us to our second interactive activity. So putting all of that together to come together to this, we're going to start off by mapping out some of the places for intervention to mitigate those policy-related impacts on health inequities. So if you think back to that first table, let's say you did that first interactive activity, you did that first table, select the top three health disparities or inequities that affect the population that you and your program serve. So with those three health disparities or inequities in mind, first think about the external policies that affect your client population's ability, right? So these are the policies that are outside of your organization, but that have an impact on your population's access or utilization of care. So what external policies serve as barriers for this population? How do these policies affect your population's ability to use your program services? Are these policies changeable? And if so, what would it take to change these policies? And what are those external policies that facilitate your clients' access and utilization of care? So you've thought about the external, now think about the internal policies. These are the policies that are in your workspace, right? These are the policies that have helped your population gain or maintain access to care. Are these policies written in stone, or are they malleable, right? Can we change them, or are they unchangeable? How can they be modified to improve program engagement, utilization, and retention? So with all these questions in mind, complete the table on the next page. This is where you take your top 3 disparities that you identified from table 1 and put them here on this side over here, and then go through and answer these questions. How does this affect your client's ability to access or use your program services? And how do you know that? What data do you have to show that this is really having an impact on the access and utilization of services? And can policies be modified to address these barriers? And also, if these changes were made, what health outcomes or improvements would you expect to see if we made those changes? So I'll have you think about that. Hopefully you'll have a chance to do this after this presentation. But in the meantime, I believe we're going to be having a live discussion soon. So thank you so much for your time and attention. I look forward to talking with you.